Hello and welcome back to Mostly True Psychiatry with me, Dr. Mellon. This is going to be two videos on the mental status exam. There's already one uploaded that is on the history of the mental status exam according to Dr. Google Scholar. And this first video will cover everything except for cognition, insight, and judgment. So it's these appearance, behavior, motor behavior, speech, mood, affect, thought, process, and content disorders. With lots of side comments, trying to make this really relevant to being an actual psychiatrist and not a textbook. So appearance, definition, how the patient looks. However you want to do it, go for it. Things we put in appearance typically are going to be appropriateness of clothing and accessories for this situation. So this person is in a desert, they are wearing lots of warm clothes, not appropriate. Otherwise, it's usually appropriate. Build, this is how you can fat shame people and stuff, I guess. Morbid obesity, heavy set, average build, thin, muscular, petite, body shame away. Put it in build. Clothing description, just whatever it is. Casual, hospital clothes, street clothes, t-shirt, blue jeans, whatever your attendings at your institution like to write. And then emotional facial expressions can be here. In practice right now, modern society, most places, as taught by textbooks and institutions, you're going to put this as affect or behavior, one of the other sections, but it can also be here in appearance, and there's nothing wrong with that. Historically, it's been done that way. Grooming, hygiene, posture stuff goes here. So grooming, are they well kept, unkempt, disheveled, to give an idea of how bad their clothing setup is or their ability to keep from being looking soiled and dirty. Hygiene, bad dentition, poor, soiled, strong odor, this kind of stuff. Posture, basically, are they real stiff? And you're not wanting to say it's actually due to, EPS, it's dystonia, or are they just a stiff kind of dressed that and sit that way and present themselves that way versus slouched in their Eeyore and they're sad or whatever. We like to tell about how good people look for their age. Looks older or younger or stated age. Basically, realistically, people look older than stated age because they smoke tons of cigarettes and they're out in the sun. I don't know. I guess, whatever. Major just parts of their body, disfigurements, scars, tattoos can be done. So then we're trying to think about what are situations where a patient's appearance is actually important enough to not cut and paste it in your mental status exam. Poor hygiene and grooming can be helpful because you're basically saying they either have a poor level of functioning and schizophrenia or substance use disorder. That's why they have bad, hygiene right now, grooming. Or it's they have depression and you're trying to give that information to show that they have severe self-neglect kind of stuff going on. Abnormal clothing combinations or accessories. This is mania, schizophrenia, or you're just racist or something because it's part of normal culture variance, whatever it is. Tattoos and scars can give you cultural identity information stuff like Hispanic culture, tattoo their loved one on their neck or whatever. That's kind of relevant in that situation. Might tell you at least about losses or something in their life. Gang affiliation. I'm not good at this stuff, but I'm sure some people enjoy that and they're gonna do that. I just treat everybody the best you can and don't play favorites or be weird. Loss of loved ones, I'd be the neck tattoos or whatever. Physical trauma, right? If they're amputee or something, lost a limb. Stiffness can go here. So if a person it's very stiff, then you're thinking, is this dystonia? Is it a neurocognitive disorder issue? Is it back pain, right? People look all weird and they can't move their lower back, then they look real stiff. Slumped posture, depression being the thing, right? Or they're teenager, right? And they just don't want to be there. That's another way. Flashy or seductive. You're supposed to think histrionic personality disorder. Again, normal cultural variance, especially if they're teens, 20s. It's not, whatever. Leave it. It is what it is. So, you would use some of these terms. You'd want to describe the appearance. If somebody walks in and goes, "I am the man bat," and they look like this, then you might start going through and go, okay, it's inappropriate clothing in this situation. He is heavy set. He's pretty sweaty. He's dressed in a costume, so he's either messing with me or malingering or something. Probably. He's on drugs. I have no idea about grooming. I guess his hair looks kind of bad, maybe. Yeah, you can write whatever you want. I'm not going to. Same thing, like if you had ER, somebody's real sad, depressed comes in, then, you might want to put what are things, like if they have their poor hygiene, their poor grooming, if they're unkempt clothes, that kind of stuff. Maybe they've got obvious severe disfigurement right now, and it's just, they're depressed because they're dealing with an acute stress disorder, and they've had physical trauma. Behavior. Oh, I'm blocking my little person. We'll move it up here. There we go. So behavior, definition, global description of how the patient is acting and moving. Excludes motor activity and neuromuscular disorders. So it's how they're moving, unless you think it's due to a drug or brain issue, like a quote, organic issue, at which point you don't put it as a behavior. So some of the ways people describe behavior is going to be like the timing description. Like they were totally normal, things were fine, they're hanging out there, talking to people in the ER and staff, and they see you and they start getting sad and moan. They can't, you're like, okay, there's a game here. So patient's behavior changed upon MD entering the room or whatever. It's basically like the observation of them, and then when you walk in and they see you and they start acting differently. Level of distress, not distress, moderately distressed, severely distressed. Severely distressed matters, the rest probably don't, but it gives you an idea that if a person's very, very bad historian, not being real helpful for the interview, or you ended up giving them medications real quickly and it's inpatient kind of setup, then level of distress might get you there. Or it's PTSD and you're trying to indicate that or whatever. Avolition, there's going to be lots of words I don't pronounce like you, so you just have to deal with it. What it just means is like a lack of motivation, no initiation. You're just kind of sitting there passively. When it's severe enough, there's a general reduction in purposeful movements generally, right? You're thinking severe depression, you're thinking somebody who's like negative symptoms of schizophrenia, things like that. At that point, you might have enough avolition. It's part of the description of why they have poor hygiene and other stuff going on. Cooperation towards interviewer. This is a part that's been part of the MSE for 100 years in various wordings of it. But the basic concept at one level could just be they're cooperative with you, partially cooperative at some points, or they're just not cooperative. It could be that they're partially cooperative. It could be something like that they're disinterested or reluctant. Part of the reason that they're non-cooperative actually be they're hostile towards you, right? That's relevant. Another way you can talk about cooperation is like difficulty to redirect them, right? They're not cooperative because you can't keep them on topic. It's mania kind of thing going on. And if you want to write it, it's relevant. You could say that they're not cooperative in the setting of not wanting involuntary hospitalization, right? Like or we could all lie to each other and we would pretend, and you just skip that in the paperwork. You do you. Behaviors, you could mention things where they're responding to internal stimuli, right? So psychosis, schizophrenia, drugs, that kind of thing going on. If they're continually scanning the room and startling easily, or those kind of stuff, because you're trying to say it's anxiety, PTSD, something like that, or psychosis. Are they excited? There's a behavior, kind of jumping around, real energetic. Are they aggressive? Are they agitated and just like things are bothering them? Aggressive is like they're like trying to hurt somebody, or they're going after them. They're very passive or just disinterested. They're not interacting. They often put eye contact as part of this, so it's the way that they really kind of use this. So they always say good, poor, piercing. So piercing, they're like, sometimes you see someone with schizophrenia or doing something, they're really looking at you, they're real hostile. Oh, okay, sure. Too much wide your eyes, right? And then we all get weird about that. If it's poor eye contact, they're depressed, they won't make eye contact, and kind of like when some people won't talk to you without like looking away. They won't just look at your face. But it's also poor eye contact, like, oh, look, it could be autism, right? That kind of thing. Some big terms that matter when it comes to behavior that are kind of diagnosis terms that you put in. They're red flags. You don't write them unless you're talking about something specific kind of thing. It's thunderclap headache. You don't write that unless you're like, okay, I'm treating this right now. It really matters. They might have a brain bleed or something going on. You don't write these words, some of these words, unless it's specifically because it's for that issue, that condition. So negativism, opposition or no response to instructions or any kind of external stimuli. Like basically have to sternal rub them to get them to do anything. Don't write that unless it's like mine's going blank. Catatonia. Well, catatonic stupor is the next piece. I should just read below that, huh? Catatonic stupor. So unresponsive to nearly all external stimuli except pain. Even when I give myself hints, I don't take them. Unresponsive to nearly all stimuli except pain is a catatonic stupor. Typically, it's like they're not really responding to anything. It's a severe altered mental status kind of situation. You have a person vigorously gesticulates, or they're talking with their hands and they're moving around, and some people, you tie their hands together and they can't talk to you, but it's that kind of thing, right? They're making gestures, a lot of them, while you're talking to them, and then spontaneously begins to dance. Probably drugs or mania. People will typically do that. What are situations where a patient's behavior is important to note? So when are you not going to cut and paste it, kind of thing, or what are some examples of when you don't just cut and paste behavior into your section? So severely distressed. When they're really, really distressed, probably should note it. You shouldn't just ignore it at that point. So that's your recent trauma. They're currently psychotic. They're intoxicated. They're wanting but unable to leave. You may or may not. I think 99% of psychiatrists will say, I will not in that situation, but you should. You're playing a game, not writing real notes. Cooperation. So it doesn't matter when they're cooperative, and it doesn't matter if they're uncooperative, but sometimes it matters. So completely uncooperative person, you're saying this is the reason they're a poor historian, or I can't get any information and my note sucks. I can't get the stuff that I need to write my note and get a proper diagnosis. If they're intermittently cooperative, then you're kind of getting superficial answers to stuff, and then maybe you kind of note that. Hostile, that matters. Like your note might be like unable to assess on 50 things, and you just had like 2 lines, and you had to walk out of the room before you thought they were gonna like punch you or something. Not super common, but if that happens, you should. They're just straight up hostile. That's why the treatment began, and we had to re-interview them again later, kind of thing. Unable to redirect. They're vigorously gesticulating. They're disinhibited, stripping, standing on tables, walking around, standing in front of the room naked, that kind of thing. Dancing. You're doing that because they're manic, they're psychotic, they're intoxicated. And anything you're writing in MSC to some degree is also just so that you have those objective pieces, right? So that you can say why you're making the diagnosis and treatment choices that you are. Okay. Psychosis statements and avolition. So person's really psychotic and they're internally stimulated and that kind of stuff, which I guess is really what I meant by this. Then it's part of the reasoning. You might be saying they have lack of capacity for medical decisions right now, and you're going to seek involuntary admission, that kind of stuff. So if you're part of my residency or stuff, then we would do these kind of things as well. So we talk about, like, here's Luke Stoltman. He's purported by him and his brother to have autism, and he was the world's strongest man in 2021. He looks very much like he's a proportional human being, but he's like 6'9", so that is a 400-pound human being right there. Big brother, strong man. Little brother got to be even bigger, strong man. So if he's autistic, and you have to think about the ways you'd want to describe folks with autism. They have a lot of buzzwords and things that are attached to them, like poor eye contact, talking about them using third-person statements and stuff. But that'll be a different lecture, a different day. Kind of Marcellus Wallace after Pulp Fiction experience, right? PTSD, trauma experience is really bad. Person might have a lot of descriptors that might be relevant at that point. Here's kind of a picture of a patient who's end up kind of like a catatonic situation. So motor behaviors. Description of patient's movements, extrapyramidal symptoms and neurological issues. So dystonia, we'll talk about the first piece for motor behaviors. So again, they're just movements that are that are more neurological and reasoning. So they're not just behaviors, it's motor behavior, whatever that we want that to mean, but that's the term used currently. So dystonia is a sustained posture produced by continuous muscle contractions, right? So the classic one is I give you B52, I give you B52, I give you B52. At some point, your like head's arching, or you're like curling in and locking. Muscles will you'll start getting a tremor at some point, right? Sometimes you get get a dystonia for around your eye, right? Oculogyral crisis, and your eyes are open up real wide. You can't move, teeth are gritting, that kind of thing. It's dystonia. Dyskinesia, tardive dyskinesia. So tardive dyskinesia would be late. Dyskinesia just means that it's happening. A person like walks by another area and I just get distracted. All right, focus. So tardive dyskinesia, or dyskinesia. So they're just abnormal or impaired voluntary movements. Full stop. Anything you want it to be. But tardive dyskinesia is typically specific where it's been 2 months since you started a dopamine antagonist. Not that you're using a dopamine antagonist for 2 months, but I gave you B52 once. Haldol 5 milligrams, Ativan 2 milligrams, Benadryl 50 milligrams, or 25, however you want to do it at that moment. That you have given them that shot, waited 2 months, and they have some kind of weird movement, or moving around, or whatever it is, that you can call that tardive dyskinesia at that point, and dyskinesia during those first 2 months. It doesn't matter what type of abnormal movement it is. It can be head, neck, arms, legs. It's not gesticulating in the middle of the body. That's conversion disorder. Two terms that get used a lot. We have the psychomotor retardation and psychomotor agitation. So psychomotor retardation is the one place we still use retard in our terminology in psychiatry. It's bradykinesia. These things have, I'll just say this now because people are going to think differently and argue and be angry or something going forwards with a lot of my statements. When I did the history piece and I went back to like 1800s and pushed forwards and looked at textbooks and all this stuff from the last 100 years, most of these terms are super arbitrary. They don't have real definitions. That's why there's not a definitive source for any of this. There's not a definitive source for the mental status exam. There's not an agreement of what goes in the mental status exam, how many categories there are, any of this stuff. You just feel like it's true because you have 20 years or 30 years of textbooks that cut and paste each other, and so now it must be true. But you can think of bradykinesia, now saying all that, big caveat, these are the definitions the way I use them. So psychomotor retardation, you just think of as bradykinesia. It's slowness of movement. They're not doing a lot. So this is a person who's either they'd be very depressed and they're hard to get moving, severe depression, not like a little bit, or they have real bad psychosis, it's, like schizophrenia, and they have a lot of negative symptoms, that kind of thing. Or bradykinesia because you've been given B52, right? Thorazine, and they're just not moving a lot anymore. Psychomotor agitation, so instead of being slow movements and not a lot of movements, it's more movements, you're really active, that kind of thing. So hyperkinesia. You're probably better off just saying bradykinesia, hyperkinesia, get rid of the retardation, agitation angle, because half psychiatrists don't even know the difference between agitation and anger, right? So it's old terms, very imprecise, don't get used well, so drop them. That's been an argument since like the 60s and 70s about the MSE. Motor behavior, Parkinsonism. So Parkinson's disease is famous for rigidity, bradykinesia, and pill rolling tremor. So if you give a lot of D2 blockading drugs, the antipsychotics to people, you can get the 3 signs of Parkinson's, you get those same kind of things. The tremor is usually real mild, though, relative to what you can have with Parkinson's. And so that's, if you're using the term Parkinsonism, that's fantastic. It exactly describes what you're trying to point out. You don't need to feel like you have to write a paragraph. One word does a great job in that situation, and you need to try to help them get rid of the drug side effects at that point. For tremors is a motor behavior, so it's a somewhat rhythmic contraction and relaxation of muscles, right? And then leads to a shaking motion because you contract, release, and you end up doing this. And if you want to go to neurology, our terms are used really weird in psychiatry. It's just kind of the purpose for how we diagnose and treat. It's not really what's like the most accurate, detailed version of everything, even though we try to pretend that at times. So, you can break up tremors in a lot of ways. It could be a resting tremor and they're just sitting there shaking. It could be an action tremor where I want to get my water and I'm like, okay, oh gosh, I'm going to get it. Got it, And you could say resting versus action tremor and these kind of things. It's just send them to a neurologist or stop giving the dopamine drug or whatever. It's fine. Tics, so it's a sudden, so it's like boom, there. Non-stereotyped, so it's not like it's not something that's happening over and over. Rapid and recurrent movement. So tics can be, vocal or physical tics kind of thing. You'd be doing some with your neck. You'd be doing, sounds, like, whatever, clicking, something going on. Obviously super important if you're doing, Tourette's disorder, tic disorder, that kind of stuff. Stereotypy, another way for is saying repetitive behavior. Hopefully people know what stereotypy is. Everybody understands repetitive behavior. Pick your version. It's just a ritualistic, some kind of motion that's happening over and over. It's like a movement or a posture or an utterance. It's not goal directed. They're not trying to get anything. So it could be like you start marching in place, right? That's like the 1950s thing for like schizophrenia and 1920s and stuff. Like, oh, look, marching in place. I've never seen anybody do this in the last number of years, but waxy flexibility is a famous one in psychiatry. It's a schizophrenia concept, Dystonia kind of thing. So it's an even and slight resistance. So there's some resistance, and it's kind of a continuous resistance. It's not like easy. It's just kind of hard to push. It's got some resistance of the limbs, and then wherever you stop pushing it against, that little like resistance, when you let go, it just stays, right? So it was that woman several slides earlier where she was like stuck with a hand up in the air and was just kind of sitting like that. It was a bad day. Did you telemedicine? You're like, can you move their arm? Trying to figure it out. It feels weird. You just kind of guess and go. Posturing. So spontaneous active maintenance against gravity. So waxy flexibility just sits there. You move their arm and then it stays. Posturing is this, they go, and they stay. Like this gentleman here on the screen, right? I'll move this out of the way. So we're going to say, I'll make it up. She walks in the room and he's standing like that. He just moved into that position. So he moved in that position himself. So he's posturing. Now, if he's like moving over and over, then he has a repetitive behavior. You can call it stereotypy. That's fine. It's not flex. If the nurse or doctor right there is being weird and he's actually was like catatonic and she's just pushing his limbs into that situation, he stays, and then it's waxy flexibility, and then the doctor is just kind of messing with them, I guess. It's old enough. They couldn't treat it, right? I guess they would give you chlorohydrides or whatever back then, maybe electrocute you. Motor behavior. So some other ones, you have mannerisms. So it's odd kind of characters of normal actions. Like I'm going to keep buttoning this, and I'm going to button again, or I keep acting like I'm doing, manipulating some object over and over, like it's happening. Abnormal gaits. This gets as detailed as you want. This is a neurology exam. I mean, are you talking about antalgic gait? It's pain or whatever. Yeah, stiff gait. Maybe that matters. Shuffling gait. If you caused it, you should put it. That's a real term. Fun term. You may never get to use, but abeja gait. So it's a form of conversion disorder. You're just writing it down because it's like they have some weird motor movement thing going on where I can't walk and I can support myself here and do this, and it's like, they can walk fine. It's all behavioral, and that's abeja gait. ADHD kind of folks or something, you might want to say fidgets, squirms in seats, difficulty staying in chair, often on the go as if driven by a motor because you're cutting and pasting out of the DSM diagnosis. Jittery, you can kind of mean like tense, or you could say anxiety-related jumpy movements, easily frightened. You can use one of those as an adjective or whatever. These are all words that I got from books and the way that they've written it. It doesn't matter. Pacing, so akathisia stuff, that's a way to mention it. If that's where you want to put it and how you want to put it. So where to write posture. Let me have another drink real quick. All right. So does posture belong in appearance? Oh, this is just like a question I was trying to think when I was thinking these things through. Does posture actually belong in appearance or motor behavior, right? Here's the problem. Here's the way. So it could be they're slouched or whatever, right? They're stiff. This is the problem where the language and the way the MSC was built is not good, and it's not meaningful in a lot of ways because you have these overlapping scenarios, and it's like, well, it depends on how you use it. And it's like, you should have better categories then in the way that you're defining and using stuff, because it could be in both. It just depends on what you mean by it. So what are situations where you really should make sure you're not just doing cut, paste, Control-C, Control-V, and moving on? Or if you use something smart like a text expander kind of program and just snip it, dump, and move. So if they're slow, they're rigid, they're tremoring, you open up their mouth, and it's like tremoring too or whatever, then, you might have given Parkinsonism, and you should probably write that down. It's a side effect and you need to treat it. Don't hide stuff. Don't be weird. Don't just if there's something that happens, it's part of medicine. Just acknowledge it, figure out what the problem is, treat it, and move on. Psychomotor retardation, so bradykinesia. So that happens if you get a severe depression, right? Like you're going to go shock the person kind of thing. They're not taking care of themselves. They're like not eating right or anything anymore. You really should write that down there. Neurocognitive disorders, generally, if people have weird movements and there's a neurological situation and you understand it enough to at least describe it, you probably should. It'll help out the neurologist or the next person know what they're getting consulted for. Psychomotor agitation, hyperkinesia. So cocaine, meth, something like that going on, mania, psychosis, that's fine. If they have a very strange gait or movement pattern and it doesn't look psychotic or it doesn't look organic, I don't know why I wrote that. Let's just fix that on the fly. It's conversion disorder, right? Dystonia, Beja gait. If they're constantly pacing, you should mention that, and then you're like, wait, I'm really bad at this. Are they being aggressive? Do they need some more Haldol or aripiprazole? That'd be a good one for this one, right? Aripiprazole, and like, oh, they're getting more agitated. They're pacing around. More aripiprazole. Oh, they're still pacing. More aripiprazole. It's right. Akathisia, that's a problem there. So you got to have a way to say it and do it. And psychosis, and people that just schizophrenia, they'll walk for 10 miles sometimes at a time. Just depends on what's going on. Or you get pacing just from dementia and stuff. I mean, so there's some different situations. If you're looking at somebody that has negativism, you're using words like rigidity, mannerism, waxy flexibility, posturing. These are motor behaviors that are relevant to catatonia. So catatonia can have negativism, rigidity, mannerism, waxy flexibility, posturing. These are all probably not all at once, right? But you can get these pieces. So what a lot of hospitals do and stuff in the U.S. is they'll do the abnormal involuntary movement scale. I don't want to open up in a webpage right now. I'll just kind of make the main points. We'll move on. But it gives you a way to at least you have a quantitative set of information about abnormal movements. It's specifically used in psychiatry for patients that are on antipsychotics. You might be at a state hospital or something. They just dump it on everybody, and we just do it for everybody, but I mean, you could do everything for everybody, but that doesn't make sense. It's like doing a 50-point review of systems on a person who comes in with a skinned knee. I mean, it's weird and not appropriate. But so if somebody's on antipsychotics, it's very typical to use it because the AIMS, this test, the AIMS test, basically it's open source. You can go to Google. The first two hits, they'll just be ones you can just download, and they're fine. Print them, they'll put them in your EMR or whatever, and then you'll get to click and fill it through every time. Hopefully they have one that says negative or something to just go through it. But so it does not diagnose tardive dyskinesia. It doesn't have cutoffs to tell you at what point that they're getting better or worse. So it's just this 12-point scale. It's got a couple, you have to read it because I have one or two, and it's like that aren't Likert scales. The rest of it's 0 to 4, where 0 is totally normal. It doesn't exist. They're not tremoring. They're not stiff. They're not doing any of this stuff. And then 4 is it's really bad subjectively. And then basically it's like it breaks it down into pieces. Like it shows here, the question 1 through 4 for oral facial stuff, and 5 to 7 is extremities and trunk. You give some kind of impression of their overall level of distress and how severe you think it is, and then make sure that they don't have gum in their mouth or they're chewing or dentition that's weird or missing all their teeth or whatever. So, and then it's basically so you could look at it again later and say, yeah, they got some weird movements. Let me see what I did last time because I was the reviewer. Oh, okay, how well this gets done between psychiatrists, I seriously doubt it's good. But however you grade it, at least you could say it gives you a quantitative measure to go better or worse, right? It's like going, how depressed are you on 1 to 10? 1 is normal, 10 is you want to kill yourself. Where are you? I'm at 8. Like, okay, and then you say where they get next time. It gives you something that's quantitative. This is fun. I hope this stuff's not copyright. in a way that makes this get down. This is education, folks. So I found this fun thing. It's for Thorazine advertisement back in the day. So it's for prompt control of senile agitation. Night night, Grandpa. You're gonna lock them up. And back in the day, you knew that the neuroleptics work because they cause Parkinsonism. Or back in the day, they didn't refer to it as Parkinsonism, but yeah. So motor behavior going to cause a lot if you give Thorazine to an old person. So you're going to be talking about, tics, tremors, whatever's relevant. ADHD, they're, basic stuff. They're fidgety, can't stay in their chair, wound up like on a motor, whatever. Get you there. Speech. Speech is a little weird. I looked into this. I tried to look at, I found a dictionary there's like a Cincinnati hospital for speech pathology or something. I don't remember. I looked at a few different books and different things, and it's like the rest of the MSc. We just use it in a special little way that makes sense to us. It's not necessarily broadly applicable to other fields. It makes it a little rough in between professional fields. But you can just think of speech, as a psychiatrist, the production and understanding of speech. Typically excludes concepts of nonverbal communication. So they really mean oral. So there's a lot of things you could do to talk about it. You could talk about volume. Is it loud, normal, soft, mute? I mean, I would, you could say that somebody's like muttering softly, who's catatonic, or, maybe that's relevant at that point. Loud, I don't know, whatever. You're just trying to say they're agitated. Tone, so are they angry and irritated? Are they real timid? Tone, and they're all scared. Are they childlike? And you're like, personality disorder. You're not a good personality. Are they loud, monotone, and they're like, I have a prosody because I have autism or whatever, right? Like they're not changing inflections. I think there'll be more on that piece in a minute. But then they talk about the overall amount of speech. Is it paucity of speech, decreased speech, little spontaneous speech, any of those kind of words, just to say that they're not producing a normal amount of speech. And then you can say there's an increased amount of speech, right? Because you start going towards pressured speech eventually. And then we talk about rate. So that's like the overall amount within it. And then you could say I said that slightly wrong. I'm sorry, everybody. Ugh. So amount is like if you think there's a normal amount of information in a normal amount of time. Very little paucity of speech, normal, or they are producing a lot of just general speech for that overall time. Rate is just like they're reducing the spacing and stuff between the words until they're just super pressured and increased. Otherwise, it's more decreased. And there's like a latency, and you say something, and you're waiting for that rate. You're waiting for something to come in, and nothing happens, and boom, a word finally. Like, oh, okay. Maybe they're processing speech. They've had a stroke. Something else going on. Rhythm. So this is when you talk about is it slurred? The rhythm, they're kind of blended together. Is there like weird, poor articulation of sounds? And that starts going into more speech therapy stuff. The prosody. And dysarthria, just difficulty actually, I don't know if dysarthria is good to put here. I think I have a piece on prosody. Yeah, we'll talk about prosody in the next one a little bit more. It's a big term. It's not quite used right in psychiatry. We just mean normal, kind of, by it. I don't know. Fluency is able to speak or read smoothly. So you have to talk about verbal fluency versus, reading. But so it just means that you can kind of reasonably have a normal flow of words and accurately say the words, and you're not making like stuttering or paraphrasic errors or stuff, or word finding difficulties like with dementia or something. So some of our fancy words is prosody would be one. I started I went to some websites and I started like Wikipedia and stuff and just kind of running through this, trying to figure out what people really mean by this in psychiatry. It's one thing to say a definition. It's another one to say that's actually what people are thinking when they do it. So prosody is all the elements of speech not made up by the actual phonetic sounds, ba, ta, ja, or whatever, however many there are. So it's everything else but the fixed, phonemes or whatever they're called. Those 70 sounds or something in English. I made that up. I don't know how many numbers there are, but I've been told a few times. I just forget. So if it's not the actual sounds anymore, it's like how they're saying it. So it could be it's indicating emotion. It could be that's they're scared and angry or whatever. It could be that's the sarcasm. It's the humor portion coming in, the irony. pathologists will refer to as like suprasegments. So only way that this matters to us probably in psychiatry is we can say a prosody or prosody or whatever. But basically is when you have no variation in the way you're talking. There's no tone changes and stuff in it. There's some words aren't ending in lilts and questions and this kind of stuff. And it's I am just talking like a robot always. It's like it's one of those autism signs, right? So it's like they're monotone sometimes. So you could say that there, but I would probably say don't need to use the word prosody. Allogia. So this is poverty of speech. Used to be called empty speech at one point. Maybe still is in some places. So it just means you have little spontaneous speech, typically real kind of flat tone. You're not saying a lot of words. Long pauses, short responses. This is like if you have a severe, like schizophrenia with negative symptoms. This is where this is appropriate word comes in a lot. So they're only answering what's asked. It's like, I've had a patient where you talk to this person for a month and they've said 3 words at a time and you can't get any more words out of them no matter what you do or what topic you're asking about, things they like, anything you find doesn't help. It's in schizophrenia, so it's kind of a negative, it's part of the negative symptoms. Sorry. And then it's also called diminished emotional expression. So you could just write that instead of allogia. That's, again, just your choice of words is very arbitrary, which one you want to use and why. Often people just pick the one that it's part of the DSM to make sure that it gives you the diagnostic piece. Here's words that I didn't really understand or use properly up to this point. I just used echolalia, but there's also a palilalia. So there's a situation where you have an involuntary saying something, and so if they're involuntary mimicking another person, like I'm going to town, I got to get some candy, that's echolalia. They're involuntarily mimicking another's speech. So there's palilalia, which is when I just go, I want to go to town. It's actually very normal to some extent. If you've ever seen, adults will do it too, but if you've ever seen kids, especially when they're younger, it's where you talk under your breath, right? They start saying something, they'll say it again 2 or 3 times. That's super normal. It's just the way our brains work. But so it's involuntarily mimicking their own words. They say them again a few times. It could be a phrase, sentences, whatever. And that's palilalia. It's very normal for children of the right age who are, 7, 8, 9, 10, 11 kind of thing. Pronoun reversal, we have this term because of autism. So, it's like, he is doing good. It's like, it's supposed to be I, but, and so you're trying to train them to use the right pronouns, that kind of stuff. Yes, autism's a spectrum. I'm very aware of that. It's not all the same. I'm just trying to give you the category where these things show up. Schizophrenia is not either. It's just the way stuff. Neither is anxiety or depression. All right, so you could look at language as a big, broad category. This is just kind of a conceptual help a little bit, where you say it's like expressive or receptive language. So it's expressive language just means does the patient, it's a production of verbal or sign language, right? Production of language is expressive language. And so you're just like, does the patient express language effectively? And you just consider the output of words, the grammar, the gestures, the facial expressions, that kind of thing. So how you evaluate that, the one that's famous for us in psychiatry is repetition. You have them repeat something, and we're like, no ifs, ands, or buts. And then all the psychiatrists, as we get trained to go through medical school, like, yeah, you have to say no ifs, ands, or buts. No ifs, ands, or buts. That's garbage. It's absolute garbage. It doesn't matter what you're saying because you don't even know what you're testing. But some of the stuff that psychiatry does, just because the mini mental status exam or something exists, a bunch of people in the last 50 years were trained that way, and then we act like it's real. They've had other stuff, they were like one top pipe basket cabinet. It doesn't matter. If they just have them repeat something, and you're trying to see if they can produce language in a way that makes sense. No ifs, ands, or buts is absolutely weird and useless. And feel free to insert your favorite dog species and do something else, or cats or whatever. It doesn't matter. There's nothing special about those, and don't get caught up in the idea of psychology's normed all this stuff or something, because they didn't norm to your psychotic patient who wants to kill themselves or somebody else inside of a psych unit and they're on meth, right? Your population is not normed, so feel free to do what you want. So describing works just fine. So if there's a picture, you have probably it doesn't have you want them to describe a picture that has several actions going on. Unfortunately, that won't fit inside of your psych hospital because they're not going to show like a plane flying through and an eagle doing something and somebody jumping out of an air balloon. They're like, no. It's like a generic mountain and a stream, right? Or a pretty sky and a flower. They're not going to give you a complicated enough picture. But if you want to pull it out of a magazine or something, you can bring it in. And it just has to be enough for them to describe it, right? You just need them to be able to go through multiple things and describe in it and not just be like, there's a dog that's brown and they're done and they're staring at you because you're trying to just get them to talk. Because this is just as good at trying to figure out if you're evaluating their expressive language, then it's better, right? Realistic. It's better than saying no ifs, ands, or buts. Reading, totally fine way too, right? Have them read a passage, explain what they read. You'll get their cognitive functioning as well for. Oh my gosh. I don't want to skip through slides right now. I don't want to. Executive functioning. Jeez. Don't do this after you've been up for about 10 hours and try to start teaching. So, you just want to know, do they understand language reasonably well when it comes to receptive language? So the other one is expressive language. Now it's receptive language for that comprehension. So do they understand what you're saying? Realistically, if you're just talking to a person throughout the interview, both of these things are covered at all times because you've had a back and forth conversation. It's obvious. You can just put normal or not normal. So you could say, show me how you brush your hair, or button your shirt, or put a watch on, or whatever. Ask them to do something you think they might be able to do, and then they pantomime it. And then if they can, you're like, okay, cool. They understood what I asked, because it's weird to say, pretend you're going to show me how you brush your hair, right? It's a weird thing to be asked in that situation, and if they're able to do it, they understood what you said. You can have them write a sentence. You say, please write me a sentence. And they write you a sentence. Like, you totally understood me because you wrote a sentence, right? So there's no magic here. It's just, are you able to evaluate or not their receptive language? Let me get some more water. So you could have them follow instructions. You say, like, fold the paper in half, put it on the ground, pick it up with your right hand, whatever. That's another way to get there. Close your eyes, open them, raise your left arm, that kind of thing. Anything and everything works. There's nothing special about any of them. You could entertain yourself by changing it over time. So where is it important to write and not do the cut and paste thing when it comes to speech? These are just examples of how you really do it. So they're not saying much, and what they're saying, they're doing it slowly, so that actually happens in everything. If it's really bad, you probably want to note it, but, so anxiety can do it, not the most common, but it can. Depression, psychosis, catatonia, neurological problems, right? If they're Adhd or something really bad, it might be difficult for them. Their verbal skills, rate comprehension. And if it doesn't go without saying, because like the DSM seems to think this is important at times to point out and just treat you like an idiot, but if the person, like if English is not their first language, don't be a jerk, right? Like that's ridiculous. Don't do that. But note it if English is not their first language or there's a language barrier. So instead of not having enough words and content and speed, it could be too much too fast, right? Increased rate and amount. So anxiety do both, agitation could be this, mania, psychosis can be both, intoxication could be both. I should have wrote it up there too, right? Because some people, like this is famous for some drugs, right? They're downers, so SUD. So if somebody's on a bunch of opiates or got their poppy pipes, kind of things back in the day, that'll do it. So you could have a normal but monotone speech, which is called a prosody, with pronoun reversal. These are things you should write if it's relevant for autism. All right, so they could be fluent, means they're just talking normally, the right rate. It's not weird pausing and stuff going on. But they're having word finding difficulties. They keep getting stuck in certain places and stuff. So, intoxication, dementia, low IQ, these are all things that could be an issue there. So sometimes it's real long pauses, there's few words, they only answer what's being asked, so that's the alogia thing, so that's that term. Probably mostly use it because they're talking about schizophrenia and you're doing the negative symptoms, right? Diminished emotional expression, those kind of ideas. Slurred speech, intoxication, that'll get you there. So So if a person looks like this guy on the right, you should really focus and think about how to write it properly. He's probably not even talking to you. He's probably catatonic, and so you're going to use a lot of catatonic words to make sure you get there. When it comes to speech, he might have Echolalia, Echolalia. He might just be mute, most likely just mute, but, these, well, not most likely, but very likely. You might get the verbigeration and stuff when we get to thought content disorder, or process rather. And they might do like tics, like vocal tics, grunting, hawking, that kind of thing. I just think these are fun. So mania, you're just going to write, a lot of times you just end up writing your buzz terms down, but, so I like this. It's like mania level 1, work is awesome. Mania level 2, I'm a professional dancer. It's like Monday and then Tuesday because they still haven't slept and everything got weird. I know everybody else is bipolar. They're not bipolar. This is bipolar. It's when this kind of thing is happening. Mood. So mood affect. So mood is how a person tells you they feel. Put this over here for a moment. So person comes in, they're crying, they've got cut marks all over them. How would you describe your mood over the last week? I'm fine. So mood is subjective. Mood is what they tell you, how they feel. Proposed alternative has been emotional expression. There's 1,000 terms. Again, none of this stuff is standardized. It feels like it is just because textbooks won, but not because textbooks are correct. So it's whatever they say. So there's all these fun lists when I go through books and stuff, and I built this from a bunch of other MSc resources. They're aggravated, amused, angry, annoyed, anxious, apathetic, cynical, depressed, blah, blah, blah. It's like the real answer is what? I'm fine, okay, good, sad, depressed, and what else do people actually say? I don't know. It's like that's it. Like people don't talk like they're from some fancy book or novel. So affect. You just write whatever you said for mood. That's fine. It's that subjective thing. Yes, there's subjective pieces in the MSc. It's not just the objective section. Most of it's objective. All right, affect. So definition, it's the emotional expression that you observe. So they're like, up here, like, I'm fine, tear, cuts. But you're going to write, labile towards tearfulness, right? You're like, you're not going to, that's the affect. That's what you're seeing. All right, let's jump this over. So there's a bunch of ways affect can be described. Only matter so much realistically, but so you talk about the quality of expressed emotions, or like the intensity of expressed emotions, another way. Sorry. So the quality would be like, it's you describing what you're seeing a little bit. Like they're irritable, they're angry, they're agitated, they're dysphoric, euphoric, euthymic. Those are the 3 words I use constantly, because you just say dysphoric, sad, euthymic, fine, dysthymic, sad, and you go euphoric for good. Did I say that right? It's dysthymic, and then it's euthymic and euphoric. I said it wrong first time. They could be sobbing or tearful, happy, anxious, and then there's the quantity. So if you think it's necessary, usually isn't. You go like, oh no, they're very dysphoric. Okay, good job. And then we'll talk about inappropriate versus appropriate affect. The classic example is, so it means like how you correlate their affect to the setting. So you're like, well, they're happy at the funeral. It's like, well, you're being probably a crappy psychiatrist. You say it that way. It's like they're laughing or they're smiling. You're like, well, that's actually how some people deal with grief and stress. You're being a jerk. You also are showing how like culturally naive you are as a person. Pretty much their inappropriate affect. You're basically trying to actually say they're psychotic, and that's probably the most useless way to get there. There's a lot of better words in sections of the MSc to just say the person's psychotic, and nobody's gonna look at this one piece and go, oh, inappropriate affect, right? It's the laughing, the crying, smiling clown thing or whatever. It's I wouldn't really worry about this section too much. It's a cut and paste one piece. Range of expression. So often people put a couple of them on one tier of information and then a buzzword. So the ones that are kind of all in a line, you could say it's like normal, full range. You can say they're like a little more restricted, like they're not showing a lot of their emotions, they're trying to be tough, and then blunted, and which is more like you're saying, I don't know if this is psychosis, schizophrenia, or they're really depressed, something like that. And then if you say flat, it's a buzzword, it's a red flag. You don't use it unless you're trying to say they're negative symptoms of schizophrenia. It's not appropriate to use otherwise. Stability of their emotions. So I use this a lot. I don't care about you say they have a stable mood, dysphoric or whatever, or labile towards tearfulness or something. I'll write that to where it's it's like they did fine most of the interview, but they would start breaking down at times. And I don't want to be like, patient was a crybaby, embarrassed me and themselves, and they're like, oh gosh, they got to read their own, they get to read their own paperwork now. Oh gosh, I'm in trouble. Like, just write appropriately, right? Like, so you just say, they're labile towards tearfulness. It's correct, it's objective, it's being professional, it's fine. And you don't need to be judgmental about it. Mood plus affect. You can take them together for further evaluation. And we like to say, are they mood congruent or mood incongruent? This feels like you're doing something special, right? It's dumb. So if their mood, so if what they tell you their emotion is and what you see are the same, that means affect equals mood, which is mood congruent. You already wrote the two pieces of information. I don't know why you have to sit here and write another layer on it. I mean, it's not helpful for your assessment and plan. Otherwise, just write mood congruent and don't even write what they say, right? I don't know. And then mood incongruent, where they're coming in for overdosing and hate themselves, and then they're like, I'm fine, I'm happy. You're like, yeah, I'm still holding you against involuntarily right now because I think you might kill yourself if you leave. So here's some of those situations, right? So that's the first one. They go into the ER, they come in for suicidality with a plan, and then they tell you they're fine, and they're like crying and cut marks, and they're BAL is 2.3 because they've been drinking alcohol constantly. Yeah, and they just got taken in by the police to get in. So, it's a safety risk kind of thing. You should write it in your MSC, possible SI concerns, right? You need an involuntary hold of some sort right now. If you're admitting a patient that's severely agitated and labile, you put some of those stuff in it because it's just part of the evidence or setup because you're saying they need close obs or one-on-one, two-on-one or something for safety. Like they're very sketchy right now. They're a scary person, and they might need a little bit of time a night to sleep it off or something. Sometimes it's confusing, what people's facial expressions look like or what they mean because you're not. There's so many variances. I know you're just like white person this, black person this, brown person whatever. It's just there's a lot of variance in what people do and look like and their own families and that kind of stuff. And I bet I could have 50 responses to this picture right here for different people, and this one too. It's like, well, what are they doing? You probably get multiple answers. That's fine. That's why you don't need to hang your entire diagnostic hat. And what's even better? Ask them. And you really talk about it. What does that mean? Or I see this. Is that what I'm seeing? Interact with your patient. It'll get you a lot of information instead of just making it up in your head. We're going to skip this. That was doing stuff with the in-person teaching. Commonly confused ideas. So I'm probably the only person in the world who gets confused or used to about thought process and thought content. I probably still do. Who knows? So it's part of this list of terms that are just badly written. That's part of the reason you're confused, maybe. Thought process, thought content. What's the difference? And then they tell you the definition, and then you're like, that didn't help. But yeah, I'll pretend it helped. So the best I came up with is flip it around, right? So instead of saying thought process, say process of the thoughts. That process of the thoughts. And you're like, okay, that sounds like something. Like I can get there. So that's like the way the thoughts are moving. So this is the flight of ideas, the Klang association. It's the process of the thoughts. So then there's instead of thought content, it's the content of the thoughts. I don't know, this helps me. I'm probably just not that bright. But so this is the meanings and themes of what is said. It's the content of the thoughts. So this is delusions, overvalued ideas, SIHI, this kind of stuff. Psychosis, right? So Some institutions actually don't use the thought process, thought content kind of thing. So here's a John Hopkins paper found where they're using the formal thought disorder as the basic term for both instead of splitting them. And it's a little bit closer to what the DSM does, in all fairness. So kind of a definition that way of what a formal thought disorder means for both thought process and thought content would be an impaired capacity to sustain a coherent conversation. They said it differently, but just that difficulty of having a coherent conversation with you, and you're like, and you can't figure out what they're talking about, what's going on. So that's a formal thought disorder. But then when you read these papers, you also run into the problem immediately, and you realize that there is no real term list or anything, and people are using different definitions, and the MSC's got problems. So like this paper, they'll use things like neologisms, which is not in the DSM-5 TR. It's not used much anymore. In all fairness, a lot of times, like, it does show up in schizophrenia, but it's often just like you don't know cultural like terms and ethnic terms, like just slang, modern slang. You don't know slang. It's just like ghosted. What does ghosted mean, right? And they'd be like, well, it means you got killed. You got ghosted. Versus like, oh, it's neologism. You're psychotic. I'm going to lock you up. And then they'll use non-standard language, right? In this. So this paper used like schizophagia. That's like the best thing ever. Like, I just think that's funny. Illogicality. I feel like you're just being pompous at that point. Loss of goal. These are things that they're considering a formal thought disorder. So the process of thoughts, the thought process disorder half, when we're sticking with the normal version of these. So thought process disorders it's disorganized thinking. It's demonstrated by the rate of the thoughts, how they're connected, their thinking, like the strings of thoughts, and how they're organized, and then just how they express it, right? So there is no thought process disorder list. I know the other way that we get just lied to or just really taught badly in psychiatry is because we all went to medical school, and then you have to go on the one company site so that you can do all your standardized studying, so that you can pass all your shelf exams and your step tests, because your medical school didn't have a lot of weight on how you did. And they give you a list of thought process disorders you have to study because you get tested on them, but it's because of the textbooks the last 30 years. They're not real. It's not a real list. There isn't an official list. There's no historical concept in psychiatry about a broadly held theory of what the terms would be to fit in it or anything. So here's just an example, kind of food for thought about this stuff. So let me make my picture so you can see. So this textbook is a reprint. It's already it was only in print for a little while. But they basically reprinted a 100-year-old book by M.L. Kraepelin, Alan Ross Diefendorf, who wrote with him to make their textbooks. So this is from 1907, direct translation transcript. So it's for thought process disorders. See if, this is part of the reason, Kraepelin is so much better than Freud. So this is a direct quote, and does it sound like your mental status exam pieces and what we're doing? The chief symptoms usually appear in the manic phase are psychomotor excitement with pressure of activity, flight of ideas, distractibility, and happy though unstable emotional attitude. In the depressive phase, we expect to find psychomotor retardation, absence of all. So some of the terms you're using, it's just because he and other people used them 100 years ago, and then we just said, sure, that's the word. And then somebody else says, hey, I came up with a new word. Sure, that's the word. I came up with a new word. Sure, that's the word. And that's all that just kept happening. And now we have thought process disorders, but we don't have great theory or logic of how we use them. They're just historical terms and concepts. So the new DSM, perfectly good place to go, is a way to tackle this. So I rushed to get my digital copy. I'm sure some of you did too. I don't like their online version and presence. It's super annoying. But for the DSM-5 TR that just came out, so their requirement to be a thought process disorder, very legitimate. I like this statement. So the disorganized thinking should be severe enough to substantially impair our communication. impair our communications. It should be substantial enough to do that. So at that point, you can say it's a thought process disorder when you can't follow their thoughts and you can't communicate very well. Kind of one of the beauties of digital textbooks, if done better than the one that they did, and not trying to make sure you can't steal their books, they can make their millions for their nonprofit self, is you can search for terms and things, which is nice. So if you look up, there's a paragraph for disorganized thinking and for speech, you'll come up with some of these thought process disorders. So they'll mention a variation, or at least for tangentiality, derailment, which there is the same thing as loose associations, incoherence, which even in the last DSM, they're like, word salad's not the one we want, guys. And everybody's like, he's got word salad, because you can't make us change no matter how hard you try. Glossolalia, so we're like, yeah, we got some religious folks in there for their speaking in tongues. Okay, good job. Some terms are just very specific, so they're buzzwords for diagnosis. So you have flight of ideas. This is in mania and hypomania diagnostic criteria, nowhere else. So if you don't use the word flight of ideas, unless you're putting in hypomania or mania as part of the diagnosis. Perseveration was used as a personality disorder trait, so sure. Many of them are not even in the DSM that you're still using. So neologisms, clang associations, these kind of things. So again, there is no official list. They're not super helpful. Other people, it feels like these are real, or there's real lists of stuff because of textbooks. I'm serious about that. It's just since the 1980s and going forwards. Before that, it was one or two people, and they were like the influential person for 30 years. And everybody's like, yeah, it's legit. Have you seen this one person? It's the only thing I ever read. It's all I know. So I'll just move out. Some creepy guy I found. So let's just do the definitions so you can understand them. Circumstantial, unnecessary detail, but you eventually get to the point, right? To some degree, it's normal. Some people, it's very normal. Tangential, where at some point they were talking, they switched topics, they never came back, and so they never answered your question. That's tangential. Loose associations, same thing as derailment. Choo-choo trains aren't so popular anymore, so loose associations now. So this is illogical shifting of topics over time. Like they basically latch onto a verb or noun or something, or some kind of abstract piece, and they just start talking about that, and then they latch onto something kind of weird, and then they start talking about that, and there's no logic. When it's tangential, it's like, I like blue cars. Blue is the best color ever. I can't believe there's so many great blue things, right? Like there's you see where they went, and they just stuck with that other thing or something. It's kind of related to what they're talking about is blue cars now, but they really want to talk about blue because that's a thing to them. I don't know. So, but when it doesn't make sense while they're jumping around, or you have a hard time following it, you just say it's loose associations. And it's not like every sentence is that way, but it's happening a lot during your conversation. Flight of ideas, buzzwords, mania, hypomania. It's a conversation in which the sentences are quickly, just continuously shifting topics. So each sentence makes perfect sense if you just heard it completely out of context, just that one sentence. But then you put them together and you're like, why are they switching like every sentence or two or three? It's like it's super confusing. And that's flight of ideas. Incoherent speech, previously word salad, randomly spoken but comprehensible words. But comprehensible words, that's the piece. Because there's verbigeration, which is just like incomprehensible sounds. So the patient might be whispering. That's fine. You can use the term there. You can just put, they're muttering incoherently. It gets you to the same place. More or less, whatever. Clang association, clanging, not part of the DSM. Speech production, but you get tested on these stuff all the time, or you used to. Hopefully we don't going forward. Speech production based on words or sounds that are associated like rhyming or alliteration. It could just be me. This sounds like super racist to black people to me, but I don't know. I think it might have been a historical term, and we're like, did you know that 3 times as many people that are schizophrenic are black? This word feels that way to me, just like neologism. It sounds racist. Perseveration. So that's when it's just repeating words or phrases or ideas, which we said is Echolalia. It can be here to get to pick your box of where you put stuff. Is it speech? Is it a thought process disorder? Depends which word you use. So it's all good. Obsessive thoughts, right? That could or should fit here. I don't know that a lot of people write it here, but so if you have persistent, recurrent, or intrusive thoughts, it's a thought process disorder. I mean, this is where if these things happen on a real patient, please just write OCD or obsessive thoughts and compulsions, and then just describe and write out there. Don't like nest it in like a doll at some other section, and it makes it horrible for trying to find what you're talking about or reading, if we actually read your MSc, but we'll pretend we do. Neologism, so inventing new words or phrases, alternatively creating new meanings for existing ones, right? Inhibited thinking, another word we're not calling it retarded thinking. Because that got used too much as a on the schoolhouse of people calling each other names. So we got rid of that term for almost everything except for bradykinesia, like we said earlier. Poverty of speech or inhibited thinking, kind of same idea. So the thought process that produces alogia, so it's real, slow, not a lot of content thing. Thought blocking, sudden absence of all thoughts and mental activity. I think this is a useless term. You look it up over time. People just write flowery descriptive garbage, and it's like they're internally stimulated. They're having, actually difficulty with word finding or something, and you're just calling it thought blocking, probably. But you can just throw thought blocking and move on, whatever. But I think it's one of those terms probably has no place in psychiatry, and we should move on. Asyndetic thinking, paucity of causal links between thoughts, leading to disjointed and poorly organized speech. So they say stuff and they say another stuff. It's the same thing as like the loose associations. You could use this instead and be like, why did you... I guess a loose association, it's like they're talking about blue cars, and now it's kind of like colors, and you're like, okay, you're talking about colors, and you're talking about blue cars. Okay, I got it. You're talking about vehicles, and there's some kind of association. Asyndetic thinking you're confused. Like they talk about something, they just start talking about something. Probably has organic brain problems. They've stroked or something. But so how to write the thought process disorder? A good way to write negatives for this would just be like, there's no significant evidence of any formal thought process disorder, and then you don't write what it is. It's like, you didn't see anything wrong, you talked to them and stuff, just put that one-liner. Don't start listing them off and stuff, because there's not a real list, right? And it's shorter, it's true, I guess, it's just no significant evidence of any formal thought process disorder. That's good enough. But what about when you do find stuff and you want to write it? So I typically use the stem, something like patient demonstrated disorganized thinking by. And this is my preference, how I do it. You do what you want, but it makes sense, and you put it all in one little paragraph. A person can read it and move on. So patient demonstrated disorganized thinking by loose associations. If you have a space to write it, go for it. If you don't, clang associations, and you bracket it. And I was in the rain on a train in Maine, Bane, Cane. Ha 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 ha. I'm like, okay, good. And neologisms, boom, bracket. I got in a chemical lockup. That means we gave you, Thorazine B52 or something, olanzapine, I don't know. And they're trying to say that they got like dystonia, probably in that situation. I had a patient say it to me once. So it was after the fact. They weren't locked up at that moment. But, it's kind of a nice little tight place like this. When you have these things like the loose associations, flight of ideas, those things, you're never going to fit it in the MSc here. Like, it's not going to work because basically you're rewriting your note and you're spending too much time doing it, or B, you're jumping back and forth in your note that fast? Like, no, you're not. So what I do is, if you say, hi, I'm Dr. Mellon, how are you doing today, blah, blah, you're like introducing yourself to them. And whenever they start talking, you're like, whoa, this is weird, right at the beginning. I just start at the top of your note, wherever you were at that moment that it's appropriate, like, HPI or whatever it is. And I just start free typing what they're saying. And they'll lose me at some point because I can't type as fast as they talk. And you just ... because you just can't even finish where you're at. And then wherever you pick up again, you start writing until you lose them again, ... Do it a few times, you have a paragraph or so, and it looks crazy, and it's hard, and it's just the weird stuff they're doing and saying. And that way you could just, hear... when it says by loose associations, what I could actually do is then just write see above. Because you wrote it up there and you're not trying to figure out how to make it work here. It's in your note, you're all done. It's just, it's effective. It gets your note done. So, you're always trying to ask yourself when you're doing the MSc is there a reason I shouldn't just cut and paste this right now, right? Like the review of systems in general medicine. Is there something relevant I need to write? So if they have flight of ideas and they're super tangential or something's going on, because you need to know, because it's mania, psychosis, substance use disorder, then it's a way to give evidence for that so you can show your kind of, quote, objective findings. If they have lots of stuff that you're trying to say that this is psychosis like schizophrenia or something, you start listing out those words where it's incoherent speech, ascendenic thinking, inhibited thinking, claim association, neologisms, and whatever. I wrote inhibitive thinking twice for some reason. There we go. So I wrote two things twice. I'm crazy here. But yeah, you want to write down a bunch of buzz terms when they have schizophrenia, so you kind of know what they're doing and what it is. For your follow-up later. Someone's having to count everything, and you want to write it here for the OCD stuff or psychosis, and they're going, there's 5 chairs, there's maybe 5 of this, 5 or autism or whatever. But you're not going to write down pieces unless it matters to your diagnosis and or treatment. So we'll skip the things I did while I was in person teaching this. So thought content disorder. So content, so it's a content of thoughts. It's a meaning or themes of what's being said, not the process of those thoughts. So pretty commonly, it's basically hallucinations, delusions, overvalued ideas, depersonalization, derealization, SIHI. Some people like to throw in illusions here because that was put in textbooks 100 years ago, and Myers pushed that garbage back in like 20s through 60s, kind of, or 70s actually, and people just kept following it. If you're not familiar, the difference between a hallucination and illusion is an illusion. It means you have real information that your brain has received from the outside. So, it could be your internal sensation, or let me stop that real quick. There we go. There. Let me silence this, or it might go off again in a few seconds. Okay. An illusion means it's an outside stimulus, right? It's what a magician does. There's some kind of sensory thing, you misperceive it, and then that's an illusion. A hallucination means it's internally generated from your brain. Overvalued ideas and delusions were, I think we'll talk about these actually in the next few slides. I don't need to explain it all on the fly. So hallucinations, false sensory perceptions, they can be auditory, visual, tactile, olfactory. If you watch my schizophrenia lectures that are on YouTube, tactile and stuff are actually much more common than we give them. They usually refer to them as somatic delusions, but we just don't ask about them, so they don't have them. But it's just you're not asking it, so it doesn't exist, kind of thing. Then for delusions, the standard definition you're often given is something along this lines. You say it's fixed false beliefs that are firmly held despite demonstration of convincing contradictory evidence. So there's going to be pieces there about whether what you're doing is just disagreements or not, judgment issues kind of thing, when you go to judgment and insight. Overvalued ideas would be a false belief that's held with conviction, just like a delusion. The idea can't be senseless in context of that patient, and it can't be bizarre, right? They can't say it's an overvalued idea, and they're like, oh, there's the space squirrels that are running around, so I have to wear my little tin hat, or they're going to eat my brain and turn me into a dog. I'm like, what the heck is going on? That can't be an overvalued idea. That's a delusion. So it's got to be non-bizarre, and it's got to make sense in their situation. Overvalued ideas kind of stuff or moves into delusion. It happens in like anorexia and anxiety disorders, obsessions with OCD can do it. I need a few drinks of water for a second. You don't need the extra information. My wife just wants me to go watch the kids after this. All right. Derealization, and then we'll talk about depersonalization, right? So these are the dissociative symptoms, or parts of the dissociative symptoms for dissociations. So derealization are the situations where the outside environment, it's not you, the outside environment doesn't seem quite right, so it can seem airy, floaty, too big, too small, too close, too far out. It just doesn't feel right. waking dream, I guess at the most extreme, weird version. Depersonalization is like, I don't feel right. So these two pieces, so it's a sensation of unreality, something about you for dissociation. So these two pieces can really be kind of forced with drugs sometimes, like mushrooms and things, some other ones that are like psychedelics. So there's something about your brain that can switch on and off. And it'll show up for your patients from time to time, especially if they're like severely stressed or something. It can kick off. Which different lecture. I guess I'll go into that a different day. I don't need to dump that information right now. And then we often write suicidal ideation, homicidal ideation right here. Maybe your EMR makes you put in your little pre-made section somewhere else. That's fine. It doesn't really matter. It could be here if you want. The DSM basically is always not always, but likes to split it up. When you're talking about delusions, they have a little 2x2 concept. They have bizarre versus the non-bizarre delusions. This is where psychiatry has been stuck in the idea of explaining the content of the delusions and acting like making these categories as meaningful. So I'm going to be real sarcastic for a second so you're not confused. There is a very prominent and important part of psychiatry in the 1800s where delusions, there was a special witches delusion where people thought they were witches and they were being controlled by witches. That went away, fortunately, because we had some new categories in the 1950s where there was a special thing where people were starting to feel like people from outer space were controlling them with the satellites that were being sent up. And then there's new delusions that are real important about zombies in the 2000s and things like computer chips and stuff. It's because we all know that if you go back 100 years, computer chip delusions were real and being controlled by the internet. Think how stupid that is. It's part of your culture and information you've interacted with is going to be what makes your delusions. I mean, you're not going to come up with something that doesn't exist or doesn't exist yet. They weren't like, I have an iPhone delusion back in 1920. Like, no, you didn't. So they talk about bizarre, they do non-bizarre. You can learn these. You can look at my other lecture on the individual ones. And where it gets gray area or what he's supposed to do is the non-bizarre, because you're like, I don't know, maybe somebody is really trying to hurt them, right? Maybe they do have to worry about the mafia. I don't know. Like it's unless you do extra information, you don't really know, right? That's not why it's non-bizarre. So, yeah. And you end up with weird stuff. So classically thought. So when you look at the MSC and you rewind back to the DSM-4 time frame, the first part of the 4, not as much since the late 80s, when the textbooks took over for residents and schools. Notes were they were like writing stories back in the day. It was like, just write everything. And it's just, there wasn't like a real format to it that meant a lot. And then they tried to do some real medicine stuff and just throw that in there with neurology or something. But it was very common and normative for, they were talking about personalities, temperaments, right? Personality disorders, personality traits, because that's all psychiatry was at one point. And so a lot of people don't really write it a lot anymore. It's partly because we're not educated or trained in it very well, and we don't feel super adequate to write it. But you should write in your, we're in thought content disorders. This is kind of where they wrote it before. So that's super fine. You can be putting in personality traits or temperaments or whatever if you want to do it. And it's your way to practice over time, right? As your training in psychiatry is you try stuff out. Don't feel bad if you change it a year later, 2 days later, 2 years later. That's fine. Obsessions, it gets weird. Some of this stuff, again, it's like, is that a thought process disorder where you keep getting, maybe it's just the thought keeps popping in and it's just a repetition thing or something, or is it thought content? Like, I don't know. You could argue it both ways when you're trying to figure out how you want to describe the patients. All right, so the next one we'll do, the next lecture is just going to be on cognition. It's going to be pretty brutal. It's going to be a lot of information, but hopefully it's helpful and it makes you feel a lot, more confident about what you're doing, how and why. And so Until next time, appreciate your time. See you later.